Good evening, everyone. I'd like to acknowledge the local custodian to the land which we sit on tonight and honour elders past, present and emerging. I'm Melissa Wilkinson and I sit in the education team at the PHN on beautiful Darkinjong land on North Avoca Beach. So welcome everybody and thank you for being here with us. Just a bit of housekeeping. There will be a poll at the end of the session. I strongly encourage you to please complete that. This is how we get our data and plan future events, and your input's really important to us, and it's fed back to all the presenters as well after each session. So please complete that. It only takes a couple of minutes and it's really valuable. So I'll just remind you as well, we are being recorded and a copy of this will be available in the Education Library in the coming days, and that's a great resource. So if you need to refer back to it, there'll be a copy of the presentation and any resources that we talk about as well. Also in the handouts tonight, we have the Health Pathways handout in there that you can access while we're online as well tonight, as well as it will be in the Education Library as well. If you have any questions, we want this to be as interactive as possible. This is your chance to be able to ask those burning questions that you have, and the presenters are here for that. And we will have a time at the end of the session with the panel to go over those questions. So please pop those in. We'd love to hear from you. Dr. Ellie Warren will be facilitating the question sessions at the end as well. So the whole panel will be involved in that. I'll introduce you to the presenters tonight. I just want to say thank you to everyone for being here with us. I know how busy everybody is and we do really appreciate your time. This valuable topic, so thank you. In order of presenting tonight will be Ellen Seneff, and she's our new Manager for Disaster and Emergency at the PHN. So thank you for Ellen for being here so early to commencing. We do really appreciate that. So welcome to the PHN and welcome tonight. Dr. Kat Taylor is also with us, the Director at Central Coast Public Health Unit. I'm sure you all know her, and thank you too. I'm sure you're incredibly busy as well. Following Dr. Taylor will be Dr. Ellie Warren, our GP at Your Family Doctors, and she's also on the CCS team and many other panels with us, and is always very supportive with the PHN, and we're grateful for that as well. And we have Erica Drew with us tonight. She's our Manager of Health Pathways. So welcome, Erica, and thank you also for being here. I'm going to now hand over to Ellen to do her introduction, and then she'll be handing over to Kat. So thanks, Ellen.
Hello together, it's a pleasure to meet you. My name's Ellen Senft. I'm the new Manager of Disaster and Emergency Coordination at the PHN, based in the Newcastle office. Nice to meet you all. The last years have proven that natural hazards and infectious diseases are a major and likely threat that may profoundly affect the GP community and their ability to deliver primary health care. Disasters also threaten business continuity and challenge the mental health of health providers and their patients with long-term effects. This is why the PHN wants to assist the GP community with a strategic approach to develop, expand and consolidate their preparedness and disaster resilience towards all sorts of hazards that may occur in the future. My role will have a focus on developing such a structural multi-hazards approach that addresses the needs of our GP community and which may assist you in your decision-making process when preparing for a disaster. This tool we are developing will also give you information about resources that can be accessed to alleviate the pressure and the damage disasters may have placed upon your practice and the workforce. The organizers also asked me to provide a few words on my professional background. I have 8 years of experience delivering primary health care as a dentist in Germany. I then decided to pursue a career in public health and graduated from the UNSW Master of Infectious Diseases Intelligence program, which also included an education in managing health aspects of crisis, emergencies and disasters. I subsequently gained 14 months of invaluable experience working for a German public health department during 3 major COVID outbreak waves from 2021 to 2022. In this position, I was responsible for the administration and surveillance of 34,000 COVID cases, as well as outbreak investigations, response and mitigation planning, which included responding to outbreaks in the primary healthcare and residential aged care setting, and assisting providers in disaster management and preparedness development. During this time, I acted as a communication focal point for all stakeholders that were involved in the pandemic response. This included primary providers, school and hospital representatives, the local and federal health department, disease surveillance bodies, and the German Armed Forces IT battalion. For over 1 year, the German military had to deploy personnel to assist in contact tracing and database administrative tasks. And at times, they also deployed surge capacity personnel to heavily affected residential aged care facilities. Regarding GP services, I was involved in commissioning healthcare services such as testing clinics to facilitate upscaling measures and to relieve GP practices. After 2 local GPs sadly passed away after contracting COVID, the service continuity in the district was in danger as the GP density in the district was low from the start. I was involved in managing the systematic transfer of patients from the 2 deceased colleagues to other GP colleagues who still had some capacity or who could create surge capacity, but this was a very difficult task. It was a lot of pressure on a system that has already been understaffed and fatigued by a 2-year intensive pandemic response. And I must say that I was at all times impressed by the high level of motivation and dedication the GP community of the German district displayed and how well the cooperation was performed. It was the power of communication between a network of individual GPs that facilitated the resilience and recovery during the most horrific times with excessive workloads and high business risk. My impression is that the Central Coast GP community is equally connected. This connection will help us through the upcoming times in which we unfortunately will have to deal with the threat and effects of hazards and disasters on a regular basis. After February 2022, I was also involved in planning the primary healthcare response to an emerging civil disaster. After the Russian Federation invaded the Ukrainian country, which borders the east of Europe, my catchment area in Germany experienced an increased influx of refugees, and there was the need for coordinating and commissioning of urgent primary care services and for testing for COVID and tuberculosis. The refugee influx is still ongoing, which shows us that one disaster may be superimposed by another, and all of a sudden our priorities change and actions have to be adapted. Well, I'm very pleased to be working with the PHN, and I'm looking forward to a fruitful collaboration with GPs of the Central Coast and Hunter New England region. Thanks for your attention, and I will now pass on to Kat Taylor. Thank you.
Thank you, Ellen. That's great. I'll just share my screen.
Yep, looks great.
Oh, can you see my slides?
Yes, all good.
Okay, that's looking okay for people?
Yes, yep, perfect.
Oh, sorry. I've just got this panel sitting right where I'm trying to look. Apologies, everyone. I'm just trying to make this a bit smaller. Okay, well, hopefully you can see my slides and I can see my slides.
Yes.
So hi, everybody. Thanks very much for the opportunity to chat to you. And I realize how time poor everybody is at the moment. I have actually just returned from 6 months off. So what did I miss? It's definitely been a very interesting time for everybody. And as Ellen alluded to, you know, off the back of a very sustained disaster that, you know, we really need to move out of the emergency response framework and into kind of a recovery framework now. So I suppose I wanted that flavour to come through in this presentation of COVID and beyond. And I think we're all, you know, starting to re-emerge into the world of things beyond COVID, even though COVID is still very much with us. And we're certainly having discussions at the Public Health Unit about, you know, what does this next phase look like? So I thought I'd give a brief overview of epidemiology of COVID. Also talk about what's on our radar as public health at the moment, and also just seize the opportunity with this audience to discuss some new notifiable conditions as of the 1st of September. So this is an epicurve of our Omicron cases from wave 4. And you can see we're sort of looking at the far right-hand side of the screen here. The grey bars reflect the PCR confirmed cases and the orange the RAT confirmed, and as we all know, this is probably a gross underrepresentation given the drop off in testing. Anecdotally, maybe about half of people who are symptomatic are getting tested, but certainly we are seeing an encouraging trend of declining cases. And in the Central Coast, we're sort of bouncing around the 200 a day mark, which is certainly much decreased from what it was. And that's certainly mirroring the statewide trends. From a hospitalisation perspective and also ICU perspective, again, pleasingly, those numbers are trending downwards and sort of really turned a corner probably around the beginning of August. So very much coming off the back of this wave driven by the Omicron BA4 and 5 variants. There is whole genome sequencing still being performed on the people that are getting PCR testing. Probably about 2% of PCR sequences are going for whole genome sequencing. And over the last reporting week, the Epi week, around 75% of those sequenced were belong to the Omicron BA5 lineage. Then we're starting to see a slight uptick in some of these sublineages, which have been heralded overseas, so 7% belonging to the Omicron sublineage of BA2.75 and 1% the Omicron sublineage of BA4.6. And at the moment, it's sort of, you know, I guess each way as to which of 2.75 or 4.6 will emerge as, you know, the next, I guess, key variant. So I suppose just moving on now to acute respiratory illness. This is a graph illustrating, or should I say contrasting COVID with the influenza season that was or wasn't. Certainly we did have quite a big uptick in flu around June, but that dropped off almost as suddenly as it came, and partially attributable, you know, mostly driven by influenza A influenza cases. But we did certainly see good rates of vaccination. There was obviously a push for free flu vaccination at a state level. And so we did see fairly good coverage and matching of the vaccine with the strains that were circulating, which in part drove that drop off, but also we're probably experiencing a bit of a phenomenon of viral interference here, whereby COVID is outcompeting influenza for viable hosts. And so we can see that COVID, you know, very much was centre stage from about July onwards, and flu has remained very low since July. We have, of course, seen the impact of this predominantly in our aged care sector. You can see here that we've had about 34 of our 36 facilities affected, and we have had a number of outbreaks that have involved both COVID and flu outbreaks, but predominantly COVID outbreaks. And you can see that these really peaked in July. Unfortunately, throughout most of July and August, we had probably about 30 open outbreaks in RACFs, and many of them quite sustained outbreaks, unfortunately, you know, driven by very challenging factors in terms of, you know, residents with cognitive impairment and a lot of difficulty implementing infection control in some of those scenarios. And I'm sure you'd all be quite familiar with the challenges in the aged care sector, as well as obviously, you know, staff furloughing and shortages, which has been dealt with, which has been felt universally across the board. But I'm very pleased to report that as of this week, we currently only have 3 RACFs which have open outbreaks, and we're optimistic that hopefully those can be closed off sometime in the next week or so. And so I suppose we await with bated breath what the next variant will bring, but there is some modelling that suggests or predicts that there will be another COVID wave before the end of the year. Just wanted to flag as well, while we have seen almost universal RACF outbreaks across the coast, certainly the experience of this particular wave has been less severity amongst those affected, due in large part to obviously good vaccination coverage of 3-dose coverage and also high antiviral prescribing. So I believe that this slide has been shown in previous RACGP webinars, but essentially you can see quite a large spike in PBS services for oral antivirals in July of this year. So a big thank you to all of the GPs for your part in helping to mitigate the impacts on the most vulnerable. I just alluded to vaccine coverage in RASIF residents, and just to flag that this data is publicly available. So on the Commonwealth website, you can have a bit of a look and drill down onto the percentage of residents vaccinated with 4 doses of COVID vaccine, and that's to the level of statistical area 3, SA3. So you can see the Central Coast here has relatively good 4-dose coverage, sort of in the order of 70 to 79% in the main SA3s in our local health district. We are trying to get more granular data than that and do some specific work with the sector. And certainly there have been challenges with trying to get vaccinations into the aged care facilities. But we certainly know that there is good effectiveness of having a 4th dose or a winter dose, although we're now into spring, but having that additional dose. And also we're starting to get some emerging evidence of effectiveness even in the circumstances of Omicron outbreaks. So this particular study here, a test negative design in the RASIF sector in Canada, found it compared 4-dose coverage with people who'd had only 3 doses and found a 40% reduction in severe outcomes, and certainly an 86% reduction in severe outcomes in those that had had 4 doses compared with those that were unvaccinated. So certainly strong protection and increasing protection conferred by having additional vaccine doses. But we know that the coverage for that 4th dose can be quite tricky, and that's something that we're trying to work on with the sector in trying to lift those rates. Oops, apologies. So I suppose the key things from a COVID perspective are there's been some policy changes. As of Friday this week, there will be a change to the COVID case isolation rules. Case isolation will be reduced to 5 days rather than 7, with the caveat that the person is asymptomatic at day 5, and that also the 7-day exclusion period remains in workplace settings for high-risk workers, so healthcare, aged care, disability, etc. The other change is about the mask rules, which have been removed for domestic flights as of the 9th of September. So I suppose those are some things to be mindful of. But I'm sure you, like us, will be continuing to mask out in GP land. Another thing that I just wanted to flag was around COVID vaccination in children. So from Monday this week, there was a slight change. So all children aged 5 and above are recommended to be vaccinated against COVID. And previously, I believe it was Pfizer from 5 years and Moderna from 6 years, but from Monday, it can be interchangeably either Pfizer or Moderna, but the recommendation is that the primary course be completed with the same vaccine. So that's one change for the children. And then also some recent ATAGI advice relating to children in the 6 months to 5 year age group. That's a fairly restricted indication for those that are severely immunocompromised, have a disability or complex and or multiple health conditions that would increase the risk of severe COVID. And in keeping with those restrictions, the plan for the rollout amongst that cohort is for it to be offered through paediatric hospital hubs. So we're talking about John Hunter, Westmead and Randwick. So there's not an expectation that that be delivered through the primary care sector. So I believe bookings have a booking system has opened for that. But I think that would be probably through a Commonwealth website. So that is COVID. Apologies. I just wanted to quickly flag a couple of things that are on the radar that are probably creeping back into your practice as well. And this sounds a little bit facetious. Some of you may remember this TV show, What Really Happens in Bali, which was a non-exhaustive list of all of the awful things that would happen to Australians traveling to Indonesia. And just to highlight, some of the handful of things that notifications that have come across our desk over the past month in return travellers. We've seen, extensively drug-resistant typhoid cases. We've had a cholera case, non-toxigenic cholera. We've had rabies exposures. We've had suspected monkeypox. There's been a whole bunch of considerations for people returning from overseas travel. So, you know, certainly borders have opened. There's been quite an upswing in people traveling, and also, you know, people often traveling to visit friends and relatives. And we know that there are particular risks associated with this group who, you know, may feel like they're kind of just going back home and not consider the potential risks and loss of immunity that they may have had whilst in Australia. So I suppose just to bring it back to, you know, a less facetious perspective, you probably would have seen this article that sadly, as expected, the COVID-19 pandemic did disrupt a lot of crucial routine public health interventions. So unfortunately, this report from WHO and UNICEF showing that some 25 million infants missed out on routine immunisations in the past year. And that brings the levels really back to, you know, sets them back around 30 years, which is quite challenging. And we know that unfortunately around 18 million children didn't receive a dose of a diphtheria containing vaccine. And given the global nature of our world and of current travel patterns, we know that is going to be an issue, particularly if we get the introduction of these vaccine preventable diseases back into pockets of under or unvaccinated in our communities. So we certainly saw this coming to fruition in northern New South Wales, which is obviously a notorious area for lower immunisation coverage. And sadly, we did see diphtheria with a pseudomembrane, which is something, you know, we haven't seen for a long time in children in northern New South Wales. The other disease which is rearing its head globally is polio. Unfortunately, you know, so close to elimination of this disease, but now seeing a resurgence, particularly in under-vaccinated populations, which have led to circulation of poliovirus in the UK and Israel, and also parts of the USA. And there was a case of paralytic polio in a person from an Orthodox Jewish community in the USA, with links to, you know, some sort of sewage detections in Israel and also in the UK, which has actually led just in the last couple of weeks to the UK initiating a vaccination campaign with injectable polio vaccine for its children. So I guess, you know, really critical gains in public health that are at stake here, and things to really be aware of when you're seeing people who are either about to travel or who have recently returned from overseas. I won't dwell on this meningococcal disease, but obviously that's something that's been a little bit topical with the Splenda in the Grass cluster, whereby there were, I think, a total of 4 cases that had some kind of an epidemiological link to Splenda in the Grass. Now, fascinatingly, there's been further laboratory typing, which suggests that probably those cases were not linked. But I suppose it's just one to keep on the radar. You know, spring tends to be meningococcal season. And just to give a little quick review of the last couple of decades of meningococcal epidemiology, we can see that meningococcal C really dropped out here in the light green following the introduction of Men-C onto the routine immunisation program, so funding of the Men-C vaccine. We can see in 2017 the W and Y serogroups raising their heads, and particularly in Hunter, that was quite a significant year for meningococcal W and Y, but then subsequently, obviously, some targeted vaccination and the ACWY vaccine introduction has led to a quite swift decline of those serogroups as well. And so now in New South Wales, we've got almost universally meningococcal B disease. So just one to be aware of. I'll keep moving on to the new notifiables. Just to flag that as of the 1st of September, invasive group A streptococcal infection became notifiable. So this one, in some ways, it's actually more lethal than invasive meningococcal disease. Obviously, quite a large spectrum of disease caused by group A streptococci or strep pyogenes infections. So, everything from strep throat, skin infections, toxic shock syndrome, sepsis, pneumonia, etc. But we're talking about invasive group A streptococcal infections, being defined as group A streptococci cultured from a normally sterile site. So that includes deep wound, deep tissue, or a surgical specimen, or typically a blood culture. So IGAS is now notifiable for the reasons of severity, as well as we have seen a change in the epidemiology since 2017, a rise in IGAS cases, and also the implications for potential post-streptococcal sequelae, such as rheumatic fever, rheumatic heart disease, and so on. So IGAS is notifiable by the laboratory, but I would also flag that there is some public health action proposed. So routine screening and clearance is actually not recommended for household and other close contacts, unlike meningococcal, unless in the setting of a cluster or an outbreak. And so a cluster is defined as 2 or more epi-linked IGAS cases in household or household-like contacts within 30 days. So I suppose that's where it would really help for GPs to keep their antennae up for if these cases and clusters are identified. One other special situation is in maternal neonate pairs, where clearance antibiotics are recommended for either the mother or the neonate of the affected pair. And public health would get involved in any outbreak investigations as well. So that's a situation where you may want to consult public health. And the other one, respiratory syncytial virus, RSV. This is just taken from the New South Wales weekly respiratory report. And you can see it was a pretty big year, 2022 for RSV, and possibly, that was attributable in some part to triplex testing. So, obviously everyone with symptoms being encouraged to get tested for COVID, and the introduction of the triple test for influenza, RSV, and COVID has probably driven some of those increases. So testing artifact, but we think it's also been quite a significant year for RSV. Obviously a concerning virus for the very young with bronchiolitis, and also the very old with pneumonia. But the purpose of making respiratory syncytial virus notifiable is predominantly to keep a track on the numbers, because excitingly there are a whole range of RSV vaccines which are in the pipeline. So it's quite amazing how COVID and COVID vaccine technology and platforms have really accelerated the development of many other vaccines that had been stalled over many, many years. So now, we're quite familiar with all of these technologies in terms of vector-based vaccines, chimeric vaccines, and particle-based vaccines. So we're, and protein subunit vaccines. So this is a bit of the RSV vaccine development landscape. And excitingly, there will be the introduction of RSV vaccines in the very near future. So surveillance has been switched on at a lab level, so probably not that relevant for you as GPs. You don't need to call us for RSV, but just to make you aware that has been a change as of the 1st of September. And so in summary, COVID is obviously on the decline, but it is here to stay. We're now in an era of endemicity, and there may be a Christmas or post-Christmas wave. We are seeing the impact of booster doses and antivirals, and so please continue to promote these, and really appreciate everything, all the efforts of the primary care sector, in particular with the RASV sector. Just to flag, beware of the returned or prospective traveller, particularly one with a fever and a rash. There's obviously lots of things that could be now. And also that IGAS and RSV are now notifiable, and please give us a call if you have a suspected IGAS cluster amongst a household. So that's it from me And I just wanted to finish by thanking the audience, by thanking the primary care sector. I heard a particularly harrowing presentation from Ellie in terms of the state of general practice on the coast, and I know it's been such a hard few years. And so just flagging, obviously, this Thursday's Are You OK Day, but just acknowledging the huge amount of work and toll that this pandemic has taken on GPs everywhere.
Thank you, Kat. It's really nice to hear you say that. It means a lot, I guess, to GPs on the coast. And it's really nice to have you back, actually. We have missed you. Yeah, thanks for that really fascinating presentation, as always. Some real pearls in there. That's fantastic. And it's lovely to meet you too, Ellen. Thank you for your talk at the beginning there. We've got a lot to chat about, I think, offline. So I'm going to try and share my screen. I'm Dr. Ellie Warren. I'm a GP in Erina, Your Family Doctors, and also in Wyong at Yeren Eleanor Duncan Aboriginal Health Centre. I wear a few different hats around the Central Coast too for PHN. Now let's see, can you see my slides there?
Yes, we can. Yep. And I'll just get you to start it from the start. That'd be amazing. Yep, perfect.
Is that good?
Yep, all good.
Good, so I'm going to present the talk. Before I do, I'd like to acknowledge the traditional owners of the land on which we're calling in from tonight, the Darkinjung leaders on Darkinjung land, and pay my respects to elders past, present and emerging. This presentation has been very kindly put together by Dr. Heather Zimmerman and JL Resink from the COVID Community Support Team, and JL is online with us tonight for some question time at the end if anyone has questions. So please do fire away some questions, or either for me or Kat or Helen or the CCST. So Kat's been over a lot of this already. We know that the current wave, COVID wave, is thankfully in decline at the moment. We've had hospitalisations down this week on the Central Coast, and deaths across New South Wales that stand at 170 in a week. 11 of those were under 65. We've had about 200 cases a day, as Kat mentioned, and a reduction in the number of furloughed staff at the hospital, and I assume that translates to GP land too, although we don't have numbers about that. Now, yes, and Kat has been over the last bits of those slides, but I would also like to just mention that the PPE national stock remains in really good position. We're ready for the next outbreak. And there have been a few questions about the efficacy of antivirals. I think that the trends suggest that they certainly have been effective, with us seeing now the reduced rates of hospitalisations and reduced severity of symptoms with the latest outbreak and reduction in mortality. So the COVID community support team at Central Coast LHD, they've also been seeing the need, a lesser need to prescribe and dispense antiviral medication from the hospital pharmacy, because GPs have been prescribing and we're getting the hang of it, which is fantastic. Now, the COVID community support team does have GPs there on site, a GP there every day who can manage people at home via telehealth, and a fantastic nursing team who keeps in touch with COVID positive patients who are high risk in the community. They register people who, need those daily welfare checks, but who are safe enough and well enough to stay at home. The idea is to keep them at home rather than bring them into hospital. And currently the CCST has 70 patients registered. JL might be able to comment at the end of the talk how many patients were registered at the height of the pandemic. I believe there were up to 400 or 500 a day, although that might have been an overestimation. That's just something that comes to mind in my memory banks, but JL can comment on that at the end. Now, the medical escalations of the CCST patients by the nurses to the GPs has also been down to only 90 requiring medical review via telehealth last month. So this is all good news. We've seen vaccination across New South Wales, about 62% who've had 3 doses. This is certainly thought to reduce the severe disease, and we're still recommending that people aged 50 to 64, certainly everyone over 70 comes forward for their winter dose, and adults over 30 can also receive the winter booster dose still. People who are severely immunocompromised can have a 5th dose if they choose, 3 months after the 4th. And as Kat mentioned, now the Moderna is available for kids from 6 months old. And John Bailey from the PHN kindly said that they're gathering a list of practices who have agreed to take on the Commonwealth rollout of Moderna for children, and John will put that up on our Health Pathways pages so that we can know where to send our kids for Moderna if they need. I might just jump out of there. I wonder if you can see my screen now. Can you?
Yes.
I'm just showing a different graph of the cases, and you can see Kat's mentioned that the cases are coming down now too, but vaccination rates are interesting. So across the Central Coast, we've got at least 90% of people with at least 1 dose who are up to date with the now it looks like with the booster is 62.5% on the Central Coast, triple vaxxed. And First Nations residents are slightly below that, so only 43% of Aboriginal and Torres Strait Islander people have had their booster, so we should really be pushing that still. Kids are vaccinated at lower rates as well, so only 74% of children over 12 are up to date. And then again, First Nations children's a little bit lower still. And the kids from age 5, really we're seeing much less of them being fully vaccinated. So still only 44% of children over 5 have received 1 dose across the Central Coast. So that's something that we can be talking about with our patients. And again, they're the First Nations children 5 years and over have a very low rate of vaccination there still. So I'll jump back into my slide presentation. So we've got, as GPs now, a new prescribing number. You all know about the COVID suitability telehealth assessment number for phone calls lasting greater than 20 minutes, where you were talking to a positive, a person who's become positive, who you're deciding whether they can receive antivirals. Now, this MBS number will be available till the end of October. Importantly, also, people who are positive and isolating at home do not need to have seen you as a GP in the last 12 months to be seen by telehealth. Now, the eligibility criteria, we're all pretty up on this now. We should be probably pushing antivirals for people over 70 or people over age 50 and over with at least two risk factors for severe disease. And that includes things like COPD, asthma, diabetes, heart failure, etc. And that's available in lots of different sources. And Erica will take you through some of our Health Pathways pages that give you some links to those important resources. Also, anyone who's Aboriginal or Torres Strait Islander who's aged 30 and above with risk factors does qualify as well. and those people with severe, moderate to severe immunocompromised aged 18 and over. So the report from the CCST is that the most people who are being registered for their service have already been prescribed antivirals in the community. So this is a really good sign that GPs are getting to those high-risk patients before they're flagged with the COVID team at the hospital. I hope we all know about the COVID Liverpool drug interaction checker, particularly for Paxlovid, which has a lot of really common drug interactions, things like statins, blood pressure tablets, anticoagulants that you really need to be careful with. And I assume actually the graph that Kat showed that shows that the antiviral prescriptions in the community have gone up in July, with the molnupiravir table from memory. Kat had a lot compared to Paxlovid, and I assume actually that's because of the hassle of going through the interactions. Possibly, I know anecdotally some GPs are just choosing to prescribe molnupiravir for convenience rather than having to spend 10 minutes going through each interaction to determine Paxlovid eligibility. So certainly Paxlovid is more effective if people do qualify for it. So we really should be taking the time to check for interactions. Now we need to remember to talk our patients through the possible side effects, consent them. There's a really nice fact sheet available from the CEC that can really just list off everything you need to talk to people about. Yeah, very, very importantly, Paxlovid does lead to toxicity of some medications. So we need to just make sure those medications that are contraindicated are ceased during treatment and for 3 to 5 days afterwards. If you decide to stop the statin, you need to stop it for another 5 days after that Paxlovid has finished. The PBS eligibility is important, and there's actually a really lovely RACGP GP prescribing workflow tool that I actually haven't seen it up on Health Pathways, but Erica, I can send you a link to pop it up there if it's not there already. In the interest of time, actually, perhaps I won't show that, but we'll pop the link there in Health Pathways, and it really just talks you through every single step of deciding what to put people on and possible interactions. Now, the CCST, if people don't qualify for Paxlovid or molnupiravir on the PBS, the CCST can actually dispense from hospital pharmacy for people who you think are high risk, but they fall outside the specific criteria. And perhaps JL, you might be able to comment on how you guys can do that and whether you've done much of that, particularly for kids over 12 who weigh at least 40 kilos who are high risk. The National COVID Clinical Evidence Task Force does recommend that those high-risk children with immunocompromise do receive Paxlovid if there are no contraindications. So that's important to just bear in mind. If we think one of our patients, our young patients, needs Paxlovid, we should really talk to the CCST. Now, remdesivir, I'm not an expert on this stuff, but this is also available as an IV 3-day course of treatment. It does require pretty strict monitoring in hospital. It's for transplant and immunosuppressed patients who are unable to take Paxlovid and with mild to moderate symptoms. It's usually organised by a specialist in hospital because of its need for monitoring at the moment. So either in the cancer day unit or the medical day unit. It's possible that if people are prescribing this or needing this a little bit more in the future, then the COVID community support team may be able to monitor and do the blood tests at home as required, but this is not really happening in practice just yet. So not really any need for GPs to be aware of how to prescribe this one. That's pretty specialised at the moment. But Evusheld is a good one to know about. Again, pretty much confined to the specialist realm, used as a prophylactic for adults and adolescents over 12 who qualify that have severe immunocompromise that can't mount a response to the vaccines. And this is really people who have active hematological malignancy or solid organ active malignancy on chemotherapy or solid organ transplants, bone marrow transplants on immunosuppression for that, who really mount a response to the vaccines, who need that extra protection. And it's been really effective for those patients for at least 6 months. So it allows them, chance to get out and about. They've really been hiding away for the last 2 years for fear of contracting COVID. And again, this is really organised only by the haematologists, oncologists, possibly the renal physicians at the moment, and given in the cancer day unit at the hospital. It's very easy for the specialist to organise, but if you have a patient who you think should qualify for this, it's super easy for the specialist to do it. GPs can prescribe this in the community, but there's not really any reason for us to do so. Really, the specialist should be taking charge here. So it would be a quick call to their specialist and see whether it's on their radar or not. So it's really not for anyone who's just decided not to get the vaccine. It's for the super specialised group. And that's given as 2 IM injections, just as a one-off dose. As I said, we can organise it as GPs, but we wouldn't really be doing so, and I don't believe anyone's done it on the Central Coast just yet. If you did decide that one of your patients needed it, CCST can help you get access to the hospital pharmacy, but can't assist with the actual administration. We'd have to do that in our clinic rooms. It is okay for pregnant women, but again, that would require specialist oversight. Sotrovimab is still available, and it's our best bet for pregnant women at risk of serious illness with COVID who are in their 2nd or 3rd trimester. It's not very effective against Omicron, and for that reason it's not being used very much anymore. And in fact, the CCST says that it was last given 6 weeks ago, and we've heard from elsewhere that it's not being used much anymore, although it is still available. So this is a really nice table from the ACI clinical guidelines, and this is available on our health pathways. It just takes you through what's what and when you would consider prescribing. There are other decision-making tools that can help. Just briefly, long COVID, there was a new update from the Critical Intelligence Unit, New South Wales Health, just talking about diagnosing and managing long COVID. It's thought that probably around 4.5% of people, somewhere between 4 and 20% of people who have had COVID do suffer symptoms for more than 3 months after the illness is resolved. The infection is resolved, sorry. It's much more likely with Delta. Once you have had 3 boosters if you've had Omicron infection. There's a similar, unfortunately that third booster dose doesn't protect you against long COVID. It's thought to have similar rates in double vaxxed or triple vaxxed people who have had Omicron. Around 4.5% of people suffer longer term symptoms, much less so in kids. It's weirdly more common in women. I don't know whether anybody understands why that is, and it's certainly more likely in those with multiple comorbidities or those who have had severe COVID infection in ICU or have been hospitalised. Most commonly is smell and taste dysfunction. In fact, in acute infections, 1 in 2 people will experience some loss of taste and smell. By 3 months, that's returned in 74%. So roughly a quarter of people still have longer term smell and taste dysfunction, which actually can really lead to significant low mood, anxiety, loss of pleasure in food, and have a greater impact on someone's general happiness. Long COVID is diagnosed by just making sure we're not missing anything else, and we really need to take a multidisciplinary approach to management and rehab, enlisting all of the services that we know so well on the Central Coast allied health teams, particularly for smell training, although I think the evidence is still out on that one, but anecdotally people have found that helpful, and just improving exercise gradually. And the pulmonary rehab team, community respiratory services, will take on people with significant shortness of breath with long COVID as well, so that's really useful for us to know. So I'll hand over to you now, Erica, for a bit of a rundown of our health pathways on COVID, if you don't mind.
Thanks very much, Ellie. I'll just swap over to present the page. Okay, can you see my slides okay?
Yep, looks good. I'll just remind everyone to pop some questions into the questions box. We really want this to be interactive, so really encourage you to do that as well. Thanks, Erica.
Thanks, Mel, and thanks, Ellie, very much for that comprehensive presentation. So, yeah, we've had a few requests just to make sure people know exactly where all of the medication-related information regarding COVID is on Central Coast Health Pathways. So these are the login details. So the Health Pathways website is available for local health professionals in our area, and the username and password are there on the screen. And then we have the companion website, which is Central Coast Patient Info as well, which is for your patients. So in terms of the COVID medication information on Health Pathways, there's 3 main pages that have the comprehensive medication information on it. 2 of those pathways are the New South Wales State Health Pathways Collaboration pages. So there's a working group of clinical editors who work with the New South Wales Health colleagues and maintain this information, and it gets distributed to each New South Wales Health Pathway region. So the COVID-19 management page and the COVID-19 medications page are those 2 pages. And then in terms of our local referral page and the local processes regarding medication access and referrals and other local information, that's on the page which has recently been retitled to COVID-19 medication access and referrals. So I'll just show you sort of exactly where that information is. So on the COVID management page, which is, I've pointed to the place in the table of contents that is located, and also you can just use the search function at the top to type in COVID management, for example, as well. And then on that page under the heading there, as you can see, the medications heading, there's a link through directly to the COVID-19 medication page. So I'll just move over to that page. So then the COVID medication page this has been redesigned. So previously the information was available on the COVID management page, but it's now been pulled out. So there's just one page specifically regarding all of the medications to make it really easy and quick for you to find during consultations. And then each of those drop downs expand and go into the more detail. And I'll give a demo after I've gone through the slides as well, so you can actually see the content within those drop downs. And then in terms of our local processes is the medication access and referrals page. So this page previously had different titles, but now as GPs are mostly wanting the information about the medications, we've retitled that page based on feedback, just so that people can really quickly and easily find that page and what the local processes are. And as I said, I'll demo that in a second. So I'll just finish off the slide and I'll pop over to Health Pathways. So can I just confirm that you can see my screen okay there with Health Pathways homepage?
Looks great. Yep.
Great, thank you, Mel. So this is the homepage for Central Coast Health Pathways. And if everybody just has a quick look at the red health alert section here, we've got the shortcuts to those specific pages that we think you'll use most often. So we linked through to the COVID management page, and then this is the link through to the COVID medications page. And similarly, that one is also listed here. And then the local referral processes page is also linked to as well. So I'll hop back to the COVID medications page and we can expand those drop downs. So as I explained before, this is maintained by the New South Wales Health Pathways Collaboration Working Group. And so as changes are published at a state level or a national level, the evidence guidelines and links are updated regularly. So there's some key links, shortcuts here to evidence and guidelines, and then the information is updated in line with those changes to evidence and policy changes. So as you can see, there's plenty of information there, and then there's lots of external links as well for useful information. And each of the drop downs expand, and then there's further detail about eligibility criteria, evidence and clinical guidelines, and patient information sheets as well. If you're ever looking for a specific piece of information on page, I'll just close these up. So over there on the right hand side, you've got the pop out toolbar. You can click expand all, and then if you use your keyboard shortcut to click on Control F, a search bar will pop up, and you can actually type in a search bar, type any sort of medication name or a particular keyword that you want to find, and then it will find it on the page. So if you just type that in and then press enter on your keyboard, it will scroll through the page to find that keyword. So just a tip to find specific information on each page. And then in terms of the local processes, as Ellie was referencing before, so in terms of our local management processes or referral processes or accessing medication, there's information on the medications here, the CCST service in this drop down. There's plenty of information in terms of links to guidelines, decision support tools, information about local support and phone numbers that can provide you with advice. And as we scroll down, the Evishield information has been recently added. There's also information about fit testing, if that's of interest to GPs. So there's plenty of local information available here. And then in terms of finding pharmacies, there's links for how you can locate community pharmacies that are stocking the medications. So please feel free to send feedback if there's something that you feel needs to be added into Health Pathways. There's always the send feedback button on each page, and we're happy to receive your feedback, and then we'll see how we can incorporate revisions and updates to incorporate anything that you feel should be added in. Okay, I might hand back over now, Mel, and we'll go to the questions and answers.
Yep, thank you so much. So it looks like we've covered a lot of content tonight and answered all those burning questions. So far, we haven't got any questions that have come through, but I strongly encourage you to please pop those into the questions box, and we can address those. So I'll just give you a couple of minutes to do that, and just remind you in the interim that this recording will be available in our education library. We are being recorded tonight. A copy of the presentations will also be available there too in the coming days. So is there any questions that you often get asked in this field that I can sort of hand over to you for that?
Mel, I just wondered if JL might comment on a couple of things that came up in the CPST discussion. JL, did you have any burning thoughts that you wanted to add, or anything that I got mixed up or confused?
Thanks, Ellie. No, I just would comment on the Evu-Shield and just give you a couple of examples of how that has been used recently. So we had a patient who was referred by her GP to our service in the hopes that we may be able to somehow get around the prescribing guidelines to give her antivirals in hand to take on holiday with her. So she was obviously not fully vaccinated, not able to be fully vaccinated, very high risk factors. She's a cystic fibrosis patient, and she was planning on traveling internationally. So this is a perfect example of where Evu-Shield was used to give that 6 months of immune coverage for this lady, so she can still go and live her life and without the fear of contracting COVID and not having access to antivirals. And in terms of, we mentioned that our team can prescribe under the NCT guidelines. So we are doing that a lot, all the time. So if there are any patients that you're concerned about that you think that, oh, they've got risk factors, I just can't tick the boxes for PBS, please refer them to us, because we can prescribe just based on clinician concern alone. So that is being used, and we are utilising that. And we did just prescribe last week to a 13-year-old who was an organ transplant recipient and obviously on some immunosuppressive medications. So that patient was able to access Paxlovid, and that was very effective. So yeah, if you've got any patients who you think that you're not sure what to do with them, you can't prescribe them antivirals because for whatever reason, but you're concerned that they have risk factors, please give us a call, and our GP VMO or our senior nursing staff can come up with a plan of action for that patient, because there is often other things that we can do to support them.
That's fantastic to know all of that. That's so practical. Thank you, JL. We did have a question from the audience about supply of antivirals through community pharmacies. I'm not sure about that. I would assume that stock is pretty good at the moment. JL, have you heard through your channels how community supplies are?
Yes, so community supplies are quite good at the moment. We have been doing intermittent updates, because at the moment there's no official channel where community pharmacies can report their stock levels, but they're working on it. So the Pharmacy Guild is working on getting that happening. So in the meantime, we have student nurses who have been spending hours ringing around, and the last update was done a week ago. So I will forward that information to you guys so that you can distribute that to GPs. and I will continue to update that information. We'll probably do another update this week because we have the capacity and we've got student nurses, so we'll send that out.
Yeah, that's fantastic. And Erica, if you could keep putting that up on Health Pathways so we know where to find it, that's great. Well, it looks like we've come to the end of the timing and also the end of the questions. I think, is that correct, Mel? Are you happy to call it there?
Yes, thank you so much. And thank you for all the presenters to being part of this evening. We really appreciate you being with us. If any questions would like to come through, you can always forward them to us at education@thephn.com.au, and we will pass those on as well. So thank you everyone for being with us here tonight. Really appreciate your time, and we'll see you all soon. Thanks. Good evening, everyone.
Thanks, Ellie. I might give you a call, unless you want to give me a call. I don't know if there's anybody else here, if it's just us. Oh, I can't hear you either. I've lost. Oh, there we go.
I can't see who else is on. There's someone else here, so I'll give you a buzz. I'm free on Thursday to chat, JL, if you want to do a Thursday.
Yeah, no problems. Did you, just quickly before you go, did you have a turnout? Because I couldn't see if there were many people attending tonight.
Yeah, there weren't all that many on actually. So, but it is going to go up on the PHN's education library, and some people watch it afterwards. So yeah, it was important to get all that really great information up there.
Yeah, I agree. And I'll forward it to all of our nursing team. I think it's good for them to hear some of the information that Kat was sharing that we don't often get filtered down to us. So.
Yeah, for sure. Do you want me to ask PHN if they can send you the link to the education library so you can share that directly?
Yeah, that'd be great. Thank you.
Oh, very good. Very good. Well, I'll chat to you on Thursday, maybe around 2:30 or so.
I'll check my calendar before I say yes.
Yeah.
Yeah, no, 2:30 would be great. I'll put that in there so I don't forget.
Actually, I could do 1:30 if that's any time between 1:30 and 2:30.
Okay, 1:30 is great. Thanks, Ellie.
Okay, champion. All right, I'll talk to you then.
I'll talk to you then. Thank you. Bye.
Thanks, Jill. Bye.